Retroperitoneoscopic assisted pyeloplasty or RAP procedure was devised to take advantage of minimal access surgery as well as skillful conventional suturing using magnifying loops. The biggest advantage is that it is minimally invasive. The peritoneum is not breached. It's highly accurate suturing without the need for nephrostomy or a stent, leads to a quick post-op recovery, and it's relatively inexpensive. The index case being shown here is a classic PUJ obstruction in a 2-month-old baby with a lump. The position for the RAP procedure can be lateral, where the surgeon stands behind the patient, or it can also be done in the prone position using 2 or 3 ports. The finger portion of a glove can be tied over a catheter and used for inflating and creating the retroperitoneal space. Alternatively, the telescope itself can be used to develop the retroperitoneal space, which has the advantage of avoiding injury to the capillaries since it is directly under vision. Incision is taken posterolaterally and deepened to split the muscles and expose the extraperitoneal space. The balloon is inserted into this space, inflated, and the space is created. The first trocar inserted, telescope introduced, connected to the camera, and the retroperitoneal space is further dissected. Once the space is created, 1 or 2 additional ports can be inserted and further dissection accomplished to identify the Gerota's fascia. The Gerota's fascia is opened and the pelvis identified with relative ease. The peripelvic fascia is dissected and the pelviureteric junction identified. The ureter soon comes into view, either lying over the psoas or having got reflected along with the peritoneum. To make further progress, sometimes it is necessary to deflate the pelvis, which is done with the help of a needle. The PU junction is held in the forceps, trocar removed, and the PU junction brought out of the incision. At this point, it might be necessary to enlarge the incision a little bit. The difference between the size of the conventional incision and the RAP incision is quite obvious. Multiple stay sutures are taken to mark the inferior pole, superior pole, and the medial aspect of the ureter. The stay sutures act like puppet strings to enable the tissue in question to come into play. Pelvis is reduced, the ureter spatulated laterally, and a wide anastomosis achieved. All the extracorporeal part of the surgery is done with the aid of the magnifying loops. The anastomosis is reposited inside and a perinephric drain is kept. The small scar of a RAP procedure vis-a-vis the conventional pyeloplasty is quite pleasing. Alternatively, a DJ stent can also be kept if desired. The perurethral catheter can be removed after 2 days, the perinephric after 3 days, and patient discharged. Thank you for watching the video.